Okay, so now I'm going to switch gears a little bit and talk about our older foals and Rhodococcus. So I did my residency at University of Florida and was really fortunate because when I was there, I was trained by Steve Giguere as one of the eminent researchers in Rhodococcus and foal pneumonia in general. And a lot of these pictures and things came from him, so I put his name on here as well. So there's a lot of information in this lecture, and I try to sort of cut some out, and I just couldn't decide what to cut out. So I will try not to go too quickly, and I'm not gonna, again, this could be multiple different lectures, so I'm trying to give sort of an overview of everything. So we'll talk a little bit about the clinical manifestations of the disease, the virulence, the epidemiology, diagnosis, control, and therapy. So Rhodococcus equi is an intracellular bacterial infection. It's an important cause of pneumonia in foals between 3 weeks and 5 months of age, and it's also seen in immunosuppressed people. It has a significant economic impact due to the loss of foals and the cost of treatment in veterinary care, as I'm sure a lot of you are aware. So this is a foal with a severe case of Rhodococcus pneumonia. This is very classic. You can see the abscesses on the surface of the lung here, and this foal, we don't see a lot of foals that get to this point anymore, fortunately, but classically they have sort of a poor coat condition or sort of ill-thrifty foals and then have this severe abscesses in their lungs. So again, this is obviously from foals that didn't make it, just these giant cavitated abscesses encompassing a large percentage of the lung tissue there. So in addition to the pneumonia, I think it's really important to be aware of where else in the body Rhodococcus can go, because sometimes we see problems that you may not be thinking pneumonia or Rhodococcus right away because it isn't happening in the lungs. So the organism can also go to the lymph nodes in the intestine. The top right picture there is the large colon, and those are the mesenteric lymph nodes, which are all very enlarged there. This foal on the left is the same as the necropsy picture on the right. This foal had a giant single mesenteric lymph node abscess that we had to drain in through the side. But the problem with these abscesses is they get very, very sticky, and the intestine sticks to the abscess, and they can have colic as a result. And this is not easy to treat. We also often see synovitis. So classically, these foals are not lame like a foal with a septic joint would be, but they'll have multiple joints that are enlarged and puffy. It can also, it's really hard to see, but it can also cause an infection in the bone itself, or osteomyelitis, which is more severe and typically does cause lameness, and it likes to go to the growth plates in the bone there. I see a few, these are really unfortunate, frustrating cases. The organism can also go to the vertebral body abscess around the spinal cord and cause compression of the spinal cord. So in the picture on the right, in the middle there, the top, that's the abscess, and it's completely obliterating the space where the spinal cord should be going through. That white tissue there is spinal cord. And this is the way they present often, down, unable to use their hind end. Uveitis, again, this is sort of a secondary inflammatory disorder, but you'll often see these horses that have green, yellow eyes. So in terms of what happens on the farm, so Rhodococcus is present in the environment of almost every horse farm. So I think we're fooling ourselves if we think we're going to keep it off of our farm or that it's not already there. But how bad the disease is on your farm is extremely variable. So it can either be completely absent, sporadic, or enzootic, meaning you have cases every year. So if we're looking at the epidemiology, we have to really take into account 3 different parts. So the agent, so the Rhodococcus organism itself, the horse's environment, and then the horse. So agent factors. So Rhodococcus is carried in the intestine of horses. It's passively carried in adult horses, meaning it just passes through. Whereas in foals less than 12 weeks of age, it multiplies within their system. And that's due to their immune system being immature and allowing that organism to multiply. Foals with pneumonia are the major source of contamination of the environment with virulent Rhodococcus. So there's two forms of Rhodococcus. There's the virulent form, which is the one that causes pneumonia and disease, and there's an avirulent form as well. So I'm not going to go into that in depth, but there is a difference, and it's important to know what people are talking about in terms of where the organism is in the environment. Rhodococcus can also multiply in the environment. It is really quite hardy, unfortunately. So if we look at farm characteristics and management as risk factors for Rhodococcus, things that can predispose are large acreage and a high foal density, a population of transient mares and foals, housing foals in stalls, and it's important to note that it's not really associated with poor management. It's these other things that seem to be taken out. So the large, well-managed farms are often the ones that have the largest problems with Rhodococcus. So if we look at if the issue is the Rhodococcus in the soil or not, we know that the soil concentrations of Rhodococcus, the virulent form and the avirulent form, are not significantly different from farms with or without Rhodococcus pneumonia, and that they are not significantly associated with the rate of occurrence. So we don't think that the soil concentrations are a big factor in whether or not we have problems with the disease. So I've actually had people ask me, okay, I'm about to go buy a horse farm. Should I test the soil for Rhodococcus? It's not gonna help you out. And we know it's not associated with whether or not there's gonna be an issue. On the other hand, airborne Rhodococcus is an issue. So the concentration of the virulent form of Rhodococcus is in the air is higher at farms with affected foals than at farms with unaffected foals. And the concentration is higher in the air samples if you're in the barn relative to air samples from pastures. That makes sense, right? You're not going to have as good ventilation in your barn as out at pasture, but that's a really important consideration. So if we look at, are the mares the source to their foals, we know that at an endemic farm that has recurrent problems with Rhodococcus, all of those mares will shed virulent Rhodococcus. The fecal concentration, so you can measure that from the mares, is not associated with risk of pneumonia in those foals. So measuring, you don't diagnose them by measuring if there's virulent Rhodococcus in their feces. And so we know that mares are an important source of this virulent form of Rhodococcus, but not to their individual foals. Now, probably some of you here have had mares who seem to have a foal with Rhodococcus every single year. And the thought is that's probably due to that mare and her foals having shared genetics, and that their genetics are making them more susceptible to the Rhodococcus that they're getting exposed to, not that that particular mare is passing the Rhodococcus directly to her foal. We know full immunology would be another separate lecture, but we know that there's a huge variation in their individual immune system, and that plays a really important role in if they get sick from Rhodococcus, if they're exposed, and how sick they get. Younger foals are more susceptible, so we think that most foals are infected very, very early in life, in the first 2 weeks. But it can happen in older foals, and again, that's likely due to this difference in the immune system and how it develops. There's a lot of research looking into, can we identify specific genetic factors that play a role likely in that immune system, and therefore if they're going to get sick or not. So in terms of diagnosis, blood work abnormalities are suggestive of Rhodococcus, but it doesn't confirm that it's Rhodococcus that you're dealing with, and this goes back to your SAA question. So an increased white blood cell count, an increased fibrinogen, or an increased serum amyloid A or SAA level can all be seen with a foal with Rhodococcus, but it can also be seen with almost any other type of infection, so it's by no means specific to Rhodococcus. We use ultrasound tremendously with these foals because it's easy to do, readily available, can be done on farm quite easily. So the picture on the left is a normal lung, and so the horizontal lines are the air artifact, because if the lung is well aerated, your ultrasound beams are not penetrating through the lung tissue, and so you just get these horizontal lines. Whereas the picture on the right is a fairly classic abscess with a capsule, and that is continuous with the surface of the lung, so you can see it with your ultrasound. Radiographs can also be really, really helpful. These are two foals with severe Rhodococcus pneumonia. The lung on radiograph should be black, like that top right corner there. Instead, you have this almost complete whiteout. And in the right-hand picture, I don't have a pointer, so it's a little challenging, but hopefully you can appreciate what we call Easter basket lesions. So there are these sort of circles with a horizontal line across it, and then the curved handle of the Easter basket, that's the capsule of the abscess, and that black area is the gas cap within that abscess. So you have pus in the bottom. If you think back to that horrible necropsy picture I showed you, you have the pus in the bottom and the gas cap at the top. So if we're talking about ultrasound versus radiographs, to me they serve different functions. As I said, ultrasound is a great, quick, easy screening tool, but you can have significant abscesses that are not continuous with the surface of the lungs, and they can hide on ultrasound, because if you have normally aerated lung tissue between your ultrasound probe and that abscess, if that abscess is deep in the lungs, you're not going to see it with your ultrasound, whereas a radiograph penetrates the whole way through the lungs. So I use radiographs to help me monitor disease progression in these foals. And again, the subset of foals I see primarily are the ones that aren't responding to treatment at the farm and come to the clinic. So not every foal needs to have radiographs, but it can be a really handy tool, and it can be done quite easily at the farm. This is the same equipment we would use to radiograph a leg. I also use it if I have a foal that has a fever and maybe a high white count fibrinogen or SAA, and I'm trying to figure out where that fever is coming from, and I don't see lesions on the ultrasound that are suggestive. Then I'll take a radiograph and see if I can find something hiding in there. A true definitive diagnosis really requires a culture. And so this is done with a transtracheal wash, which is where we take a needle and I like to go straight through the trachea. You can do this through a scope. I think it's easier to get a clean sample through the trachea. And we just put a small amount of sterile fluid in and then suck it back out. And we're sampling the trachea for bacteria throughout the lung tissue. With that sample, we can do a number of different things. We can do a PCR test, which is a very sensitive test to look for Rhodococcus. However, it's not going to tell you anything about what antibiotics are going to be helpful, and so I don't routinely do that. Culture is the most important thing, because that's going to allow you to identify if there is Rhodococcus there and what antibiotics that organism from that foal are susceptible to. It also tells you if there are other organisms there. So sometimes these foals have mixed bacterial infections. They have Rhodococcus and Strep Zo, or Rhodococcus and Klebsiella. We can also do cytology. So this bottom right picture is a picture of Rhodococcus organisms within the white blood cells in the fluid there. And we can also, again, see, we might get an indication that there's another type of bacteria there as well. And cytology samples we can get very quickly. So whereas the culture takes a few days to grow, sometimes we can get enough information to know that we're on the right track with the cytology. So our result of the culture should always be interpreted in context of the clinical signs, physical exam, and cytology. So we want to make sure everything fits. Control. So this is what we should do with all of our foals to keep them from getting Rhodococcus and everything else. Obviously not practical. So if we're looking at how we can control Rhodococcus on endemic farms, these are the four main categories. So decreasing the size of the infective challenge, identifying foals early in the stage of infection so we can treat them early, hyperimmune plasma, and prophylactic treatment. So decreasing the size of the infective challenge. So pasture rotation can be really important, decreasing the number of horses, and pasture irrigation or dust control. So remember I said that it's the airborne Rhodococcus that's really important. The soil doesn't seem to play as much of a role. So anything you can do to decrease dust, and I think that that's where this idea of pasture rotation, decreasing the number of horses is. Anything you can do, keep nice grass cover on your pastures can be helpful. You'll also, as all of us get to experience in upstate New York, there's usually snow on the ground for the first few months of foals. Those foals we don't see Rhodococcus, at least with the same frequency, until it gets warm and they're out on the dirt. One thing to mention, though, is think about the air environment in your barns. And this is helpful for a number of things, but I'm really opposed to blowing the aisles when there are horses inside, at least. If there is any way you can get your horses outside when you're going to blow the aisles, because you're just stirring out. And if you want to give foals Rhodococcus in the winter when there's snow on the ground, leave them in and blow the aisles. Because I think you're stirring up everything that's there and blowing it right into their lungs, basically. And we see this with adult horses with heaves as well, that barn air quality is really, really important. So earlier recognition of disease. So as I mentioned before, I think taking temperatures daily is really key. In an ideal world, I would have every foal be temped twice a day. Depending on the size of your farm, that's not always possible. They might not be coming in. There's a number of things. But ideally, I think that really allows us to pick up on a number of things, not just Rhodococcus, but anything that may be going on with that foal, as well as just looking at them, visual inspection, seeing if they're huffing and puffing and coughing. And if you can only take their temperature once a day, my preference is that it's done in the evening. And that's because horses have these biphasic temperature rises. So they can have a severe infection and their temperature will be normal or only mildly elevated, and then every evening they'll spike a fever. So you might miss that if you're just temping them in the morning. And then, so there have been a lot of screening programs for Rhodococcus developed. I'm going to talk about ultrasound screening next, and then using blood work. So again, this is their ultrasound, quick, easy to do. The same rectal probe that we use for checking mares is good at picking up abscesses in the lungs. So I just said most of those things. This has definitely allowed early recognition and treatment of Rhodococcus on these endemic farms and has allowed us to decrease mortality. And so it is now the exception that I see a foal that looks like that first picture I showed you that's really ill-thrifty, and no one noticed that it looked like that. We've gotten a lot better. So the recommended protocol, again, there's lots of individual variations in this, but is usually every 2 weeks, 1 to 2 weeks, from about 2 to 4 weeks of age until 4 to 5 months of age. So I'm going to go into this a little bit later, but what's really important to understand is that we now know that there are 60 to 80% of foals with subclinical abscesses that resolve without treatment. So if you are screening every foal on your farm with ultrasound, you are going to identify a lot of foals with abscesses that if you weren't ultrasounding them, you would never know they had Rhodococcus, they would never have outward signs, and they would get better on their own. So I'm going to go into why that matters in a minute. Just keep that in mind. So going back to our blood work. So there have been studies looking at how well measuring white blood cell counts and measuring fibrinogen do to pick up on these foals before they get sick. And this curve here is looking at, so an ideal test would go straight up the left axis and straight across the top. The white blood cell count is the solid black line, fibrinogen's the dotted line. So in this study, the white blood cell count did a little bit better than fibrinogen. So let's talk about SAA. So serum amyloid A and fibrinogen are both what are called acute phase proteins, which basically means that when the horse or an animal has an infection, in the acute stages, these compounds are made and the levels begin to rise. So there's now been a good study done looking at using SAA as a screening tool for Rhodococcus. And to your point, one of the problems we have is that the SAA was higher in foals with pneumonia compared to healthy foals, but there was no difference between foals with Rhodococcus and foals that had pneumonia for other reasons. So it allowed you to pick out, okay, this foal's sick, which you probably already knew from looking at the foal, but it didn't help you know that it was from Rhodococcus. And if you look at this figure on the left here, you can see, so on the left side it's clinically healthy, the middle is pneumonia from other bacteria, and on the right is the pneumonia from R. equi. And this is what we see with SAA with almost every disease, is there's this huge individual range. So you can see you've got dots way up high, even in the clinically healthy foals. You've got some that have a really high SAA. So there's so much overlap that it makes it hard to use well as a screening test, by itself anyway. So in this study, it had a low sensitivity and specificity as a screening test, and it detected about 56% of foals prior to the development of clinical signs. So depending on your situation, I mean, 56% is not great, but maybe that's better than not identifying any of them. But I think we need to use it in combination with other things. So just to show you, this is SAA versus fibrinogen. And so this, I think, is where we get into trouble with SAA and Rhodococcus, is that day 0 here on the left-hand side is when an infection or inflammatory insult occurs. The SAA gets this very high peak very quickly, and then it can come down. The fibrinogen takes longer to go up. And so if you're looking at a foal, like I've had foals that come in with obvious Rhodococcus, massive abscesses everywhere, and their SAA is normal, and that's what the study showed as well. And I think we've just missed that peak. So we're looking at them in these chronic stages of the disease when everything's walled off, the SAA may not be high any longer. So if this on the right here compares the SAA and the fibrinogen, and they were fairly similar actually, and if based on the numbers, the fibrinogen was actually just a tad better. The reason SAA is nice is that it's easy to do on the farm, and that's one of the reasons it's become popular. And so I think it will have a role and does have a role, but we can't rely too much on that and have to look at the rest of the foal as well. So plasma, how many people here are using plasma, Rhodococcus plasma? Okay. So hyperimmune plasma is obtained from adult horses that are vaccinated with Rhodococcus equi. And we know that it does decrease the number of Rhodococcus equi organisms in the lung after experimental challenge. This is a very busy chart, but just there are only 4 studies, all of which are very old at this point, looking at how effective hyperimmune plasma is at decreasing the incidence of Rhodococcus on endemic farms. In only one of these 4 studies, did the plasma actually reach significance at decreasing the incidence compared to the control foals who didn't get plasma? However, if you look at the overall incidence, there is thought to be about a 30 to 40% reduction. So you might say, well, why is it not better? Why is this plasma not more effective? The thought is that the plasma is giving you antibodies, but based on the way the immune system works and the way the disease works, the antibodies are not necessarily the most important thing for preventing that disease, unfortunately. So we really need we can't rely just on plasma, which I'm sure all of you probably have an appreciation for, but it really needs to be combined with other control strategies. Definitely, we want to be administering this before infection, and as I said, we know that they get infected very early in life. So the suggested approach is usually within 48 hours of birth. And then there is a recommendation that they get a second dose around 25 days of age. In my experience, most people now are only doing that first dose. And I do think that that is the more important time frame to do it because we know how early in life they get infected. So I'm going to talk about antibiotics in a second, but one of them that we know is effective for Rhodococcus is azithromycin. And someone came up with the idea of, well, why don't we just give them all azithromycin, starting at 48 hours of age for the first 2 weeks of life. They gave azithromycin every 48 hours. And this did reduce the incidence on this farm. It was a fairly small study in terms of numbers, but it reduced the incidence by 80 to 85%. Seems pretty good. However, there's some major drawbacks with this. The primary one being, if you're treating everything with antibiotics, you're definitely going to be treating a lot of foals that don't need to be treated. And remember, I said that we think that about 60 to 80% of them that have ultrasonographic lesions don't ever even get sick. So you're treating a lot of foals unnecessarily, or 70 to 80, depending on which slide I'm on. So that combined with the promotion of resistance makes me very wary of that tactic. So in terms of therapy, our mainstay of treatment are what's called the macrolide antibiotics. So this is your erythromycin, azithromycin, clarithromycin. They're all the same class of antibiotic. And these are great drugs for rhodococcus because they actually concentrate in the white blood cells in the lungs. And the way rhodococcus wreaks havoc is that it hides, it gets into these white blood cells, and it's basically hiding from the immune system in the white blood cells. And these drugs go right to where they need to be and get really, really high levels in the lungs. So traditionally, these medications are combined with rifampin, which is another class of antibiotic effective against rhodococcus that is also really good at penetrating abscesses, because that's a big issue we have with antibiotics, is they have to get to the site of the infection. So there has been a retrospective study comparing these three different combinations, so the erythromycin with rifampin, azithromycin, clarithromycin, and in that study, the clarithromycin rifampin had the best survival rate. So that's sort of been the go-to for a while now. These drugs do have some significant side effects, though. They can cause diarrhea in the foals. It's thought to be less severe with the newer generations, so better with clarithromycin versus erythromycin. But they can also cause diarrhea in the mares. And the thought is that the mares get exposed because they share a water bucket. And so you give the foal antibiotics, it goes and drinks water, and then those antibiotics are in the water, exposes the mare. You can actually experimentally induce severe colitis in adult horses by giving them macrolide antibiotics. So it's something we stay away from in adult horses because of that side effect. So that's something to keep an eye out on. The other thing is hyperthermia. So for years, we've been recommending, okay, if they're on these drugs, don't turn them out, especially on a hot day. Don't turn them out on a hot day in the sun. We now know that this is actually because these medications induce non-sweating. So there's this syndrome of non-sweating in horses. And at University of Florida, they showed that this is a foal getting sweat tested, which is how you document non-sweating, and this class of medications actually induces non-sweating. So we now know why this hyperthermia is happening. And then just as a side note, rifampin, which we often use with these, causes their urine to be discolored. So don't panic because a lot of people will think, oh, they're peeing blood. It's just from the medication. So there are also other antibiotics that we can use. So there are injectable forms of these macrolides, which are almost all from the cattle side of things, very powerful antibiotics in cattle. And those are gamithromycin, telithromycin, telithromycin. And there have been pharmacokinetic studies looking at what dose would be appropriate to use, but we really don't have any efficacy data to show that those are better than any of these other macrolides. My concern with these medications is that they're long-acting. A lot of them you're giving one injection a week, and if that foal has a side effect, you can't withdraw it. It's there in the foal. The other medication that we're using more of now is doxycycline, and we, again, don't have any actual efficacy data for this, but we know that it makes sense from a pharmacologic standpoint, and the reason we're using more of it is that 2/3 of Rhodococcus isolates that are resistant to a macrolide and rifampin are susceptible to doxycycline. So we've started to use those more. Gentamicin is interesting because gentamicin, if you just sort of took gentamicin and Rhodococcus in pure form, not hiding in the white blood cells, gentamicin does kill Rhodococcus. The problem is that we can't get it to high enough levels in the lungs without it causing systemic side effects, primarily kidney failure. But we know from one of Dr. Jagir's studies that if you nebulize gentamicin, it does get to high enough concentrations in the lung cells to be effective against Rhodococcus. And they're actually looking at some cool formulations of Rhodococcus that allows it to, of gentamicin that allows it to get into those white blood cells at even higher levels from a nebulizer. So I also wanted to mention this really cool compound called Gallium. This is a semi-metal that competes for iron binding sites with the bacteria. So the organisms need iron to multiply in the foal. So this is an oral medication. It's not an antibiotic, and it has been shown to inhibit growth of Rhodococcus equi in a dish. It gets good absorption, and no adverse side effects have been noticed in foals. And it might decrease the Rhodococcus equi tissue burden, basically while you're waiting for that foal's immune system to mature and fight the Rhodococcus on its own. However, sounds great, but they did not see any decrease in the incidence when this was given prophylactically for the first 2 weeks of life. So, other supportive treatments. So, again, I see the subset of foals that aren't responding to the first line of treatment at the farm. And so when they come into me, I do a lot of nebulized antibiotics, primarily gentamicin for the reasons I just mentioned. Sometimes we'll also use nebulized acetylcysteine and other compounds to help break up the mucus. Oxygen therapy is essential if their lungs are compromised enough that they're not getting adequate oxygen to their body. That top picture is just our oxygen tubing. We use an intranasal catheter to give them oxygen. NSAIDs to help control the fevers, fluids. So a lot of times these foals aren't nursing well. They're spending all their time breathing and not nursing. Environment. So I'm really lucky because we have an air-conditioned stall in the clinic, and it can make a huge difference. When it's hot and humid out, the foals come in really, really struggling, and we just leave them in the AC, don't stress them, and they can do a lot. They're very more tolerant in the air conditioning. It's a good place to hide too if it's really hot. So, and then nutrition. So we have to make sure they're eating well. So going back to Gallium for a second. So there was actually a study that looked at 54 foals that had subclinical. So basically abscesses picked up on ultrasound but didn't have any other signs on 6 different breeding farms in Kentucky. And they randomly assigned foals to receive either Gallium or clarithromycin rifampin for 1 month. Did daily physical exam and weekly ultrasounds. And so in this case, success was defined as the abscess that's resolving ultrasonographically. And so they had 70% of the foals in the Gallium group and 74% in the clarithromycin rifampin group resolve. So that seems pretty good, as I'll talk more about in a second. Remember that a lot of those foals are going to resolve anyway. So is it really the drugs that are helping, or is it the fact that they're just getting better on their own? So that brings me to my last point, which is, are current screening and treatment methods effective for Rhodococcus? These slides have a lot of words, I apologize. But basically, this group set out to look at the effect of antibiotic treatment on foals with subclinical abscesses. Again, not ones with fever and high respiratory rate and high blood work values. And this was done in Europe because no one here is very tolerant of having a placebo group. Because it's really hard when you find these abscesses on ultrasound to say, okay, I'm just going to ignore that because maybe it's going to get better on its own. So this first study, so in this study they looked at foals with abscess scores, which is basically the cumulative diameter of all of those abscesses of 5 to 10. So not foals that had small little abscesses, but significant abscess burden in their lungs, and they randomly assigned them to 1 of 5 treatment groups. So those were telithromycin, IM, doxycycline by itself, doxycycline in combination with rifampin, azithromycin with rifampin, and then a saline IM placebo group. And then they did physical exam, ultrasound, white blood cell count every week, and those individuals were blinded, so they didn't know what treatment those foals were getting. So overall, 88% of foals in this study recovered, in the placebo group, recovered without treatment. And the proportion of foals that had disease progression did not differ between any of those groups. They did see that the length of treatment, so the length of time to ultrasound resolution, was less with the azithromycin group, so those foals resolved in 46 days versus 73 days with the placebo group. But again, if they hadn't been scanning those foals, they would not have even thought that they were sick. So then we move on to, why does this matter? Well, they started looking at, there's a farm in Kentucky that started doing this ultrasound screening in 2001 with the protocol I described. And what alerted them, that there might be an issue going on is that in 2010, they had 9 macrolide rifampin-resistant rhodococcus isolates from transtracheal washes. And it's important to know that if I call them macrolide rifampin resistant because if they're resistant to clarithromycin, they're resistant to all of the macrolides. So it wipes out that whole category of medications. And so they started looking at air samples and retrospective data. And then in 2011, they did a prospective study and looked at cultures before and 2 weeks after treatment because they were worried that they're essentially seeing an increased number of resistant isolates. Again, this is really busy. What I want you to pay attention to is just these are all the years that they were scanning these foals and doing this ultrasonographic screening program. And then in the bottom right, so starting in 2001, they had no foals with resistant isolates until we get down to 2008. And then they have 4, which was 25%, 23%, 41%, 36%. So they started seeing these isolates, and there were none between 2001 and 2007. And all of these foals were having ultrasound screening done and then started on antibiotics if they noticed abscesses. So in 2011, they did this prospective portion of the study. They had 132 foals on the farm. Of those, 20% had abscesses on ultrasound. Rhodococcus was confirmed in 25 of those 27 with the transtracheal wash. And so pre-treatment, they had 6 or 25% of those that were resistant. After treatment, 2 weeks later, they have 62% that are resistant. In this study, all the foals survived, which is important because even though they're resistant in paper, sometimes the foals don't behave as they necessarily should based on your culture. But they clearly documented that there's an increased incidence of resistance with this type of a program. So I think that's really important because I'm terrified of these resistant organisms. And I worry that now, as we start to use more doxycycline, that we could just, if we are overusing all of our medications available to us, we're going to run out of classes of drugs that can fight them. And they're not, because of the intracellular nature and those abscesses that it forms, they're not easy infections to treat. Prognosis-wise, again, a lot of this data is from very old studies, but the survival rate with foals that were treated with erythromycin rifampin, this was before there was resistance, was 88%. There is a higher survival rate if they don't have any of those extrapulmonary disorders. So if they just have the abscesses in their lungs and not in their GI tract or the joints, the bones, et cetera, their chance of survival is better. In a study from foals that were referred to veterinary schools, the overall survival rate was 72%. They were slightly less likely to race than their cohorts that did not have rhodococcus, but in the foals that did race, their performance was not impaired. So what I generally tell people is typically if they recover from the infection, they can go on and have a normal career. This filly number 7 here, racing, was a foal I treated who did not read any of the books and didn't want to respond to anything. Almost gave up on her multiple times, but she had very persistent owners, and we ended up just sort of throwing the books at her, and she did great. So it's sort of my reminder that what they do, what they look like on paper, is not as important as what they look like clinically and how they respond. So what should you do for your farm? I think it's impossible for me to stand here and give you a screening plan or a treatment plan that makes sense for your farm, because it really depends on your individual situation, how many foals you have, what the prevalence of rhodococcus is. If you have a farm of 20 mares and you haven't had rhodococcus in 10 years, is it worthwhile to give plasma? No, probably not. But if you have one of these farms where there's cases year after year, and you want to be able to tell, if you're not the owner, you want to be able to tell the owner that you're doing everything you can to prevent rhodococcus, then I think in that situation, plasma is more appropriate as an example. And then obviously the dollar value of the foals versus the cost of treatment. These medications aren't cheap, and we're typically talking about a minimum of 2 weeks, typically 4 weeks of treatment. So that's the other downside to just sort of blanket treating all of these foals, is it adds up cost-wise. That's it. Questions? Yes. Hold on, Patty. The question was if there was a link between foals that had been diagnosed with rhodococcus and EIPH as adults. How close are we to a vaccine? I don't know. There's a lot of active research. Not next year. I'm cautiously optimistic it will help. It will happen someday, but it's a very complicated disease, tricky disease from an immune standpoint, which is why, if the antibodies were more important in fighting the disease, the plasma would be more effective, and I think vaccine development would be more straightforward and more effective. There have been a number that have been looked at, but they haven't panned out.
It has to do with PCR.
Yes.
And real-time PCR.
Mm-hmm.
And he believes that if you use real-time PCR, you can pick up on the initial infection in a foal or a horse, as opposed to regular PCR that gets it, pretty much after it's happened, so that possibly you could treat the horse earlier. Is that something you use, or?
So I think it depends. Basically, all the PCR tests that we run now are real-time PCR. And so I think it depends what sample you're talking about. And so people have looked at PCR in the manure of foals. And then they've looked at PCR in the transtracheal wash samples as well, which is a pretty invasive thing to do, so it's not a great just screening test. And the problem with the fecal samples, as I said, is that it doesn't really correlate great with their disease. So there are so many, on an endemic farm, there are so many that are going to be PCR positive that you're really not helping to pick out which ones are going to get sick from it. So I think real-time PCR of transtracheal wash samples, if you were able to easily do a trach wash, every week or 2 weeks, which you would never do, but if you were to do that, perhaps it would be helpful at picking up, because PCR it's an amazing technology, and it's really, really sensitive. It's just not, in this circumstance, it's not practical.
I've read a lot about gut health and antibiotics, and I just was curious, with all these antibiotics being thrown at a young horse, have you seen any links with ulcers, digestive health, things like that?
What I see in the foals with rhodococcus is primarily diarrhea from the antibiotics, or we're assuming it's antibiotics. They can also have diarrhea from all of those lymph nodes in their GI tract being infected, so sometimes they have diarrhea on presentation, which always prompts me to ultrasound their abdomen and look for enlarged lymph nodes as well. But I think in terms of links with ulcers and things like that, where we see it more is that there is an association with foals that have been sick, possibly more so in foals that have had rotavirus, and the development of duodenal ulcers as weanlings, which are a distinct entity from just stomach ulcers, but they get ulcers in their proximal duodenum, where the small intestine leaves the stomach, and that can cause a stricture there, and it's a bad deal, and can be very challenging to treat. But other than that, in rhodococcus foals, I think we're definitely causing dysbiosis of the GI tract with the antibiotics, and that's where I think as we learn more about probiotics and get better at knowing which probiotics to use when and how much, hopefully we'll be a little bit better at preventing that.
Can you recommend? A lot of our mares, or I should say some of our mares, ship down to Kentucky, and we try to hit the next cycle. So they're leaving here at 19 or 20 days. They get their first dose of the rhodococcus plasma within 24 hours, 48 hours. And your recommendation was 25 days to hit them with the next dose, but they're already on their way, and they're coming into a whole new environment with things that we can't control.
Yep.
So what would be your recommendation for these foals?
If you wanted to do a second dose, I would have no problem doing it before they ship.
Leave?
Yeah.
And what would you say would be the safe time to do that then?
I would probably do it I would do it as late as you can before. It's just that recommendation. There's not hard science behind saying you should do it at this day and then at this day. I think that early dose is is key because we know they're going to be exposed early on. My other caution about that second dose is that if they're going to have plasma is not a benign treatment, and it's a biologic product, and they can have a reaction to it. And if they do, it's much more frequent with that second dose because they've already been exposed with the first one. So we don't have great studies showing, okay, you give the plasma, their antibodies stay high for X number of days. But I agree. It's like you're stressing them by shipping them, so they're going to get to suppress their immune system that way. So I think if you are, I don't think to me there's no big contraindication to doing it a little bit earlier, because it's a pretty arbitrary number, honestly. It's just sort of trying to spread out those antibody peaks. And the other thing, it just reminds me to say that the problem with all of these Rhodococcus studies and looking at, okay, in this year we had, this was the incidence, and then we changed and started doing plasma this way, and then this was the incidence, is that we know that there's a huge variation from year to year in the natural disease, which is probably a lot of that has to do with the environment, how hot and dry it is that summer, how many mares you have on your farm that year, et cetera. So there's so many variables that it makes it really hard when we're trying to compare, group A and group B in different years and saying this is what happened, because there's just tremendous variation.
And the foals being born earlier are less likely to contract it earlier.
Yes, but they can get it. I mean, we'll see every year, it's almost like I have another peak in the fall. And I think part of that, especially if the foals are being weaned early, so then you're stressing them with weaning, and if they didn't get it before and it's still hot and dry and the organism's still around, they may, get it again. So, Hal's going to agree with me.
Thank you.
Great, thanks.
Thank you very much. And I will be here for a few minutes if you have more questions.
Thank you, Dr. Javsicas.